Hi everyone. Today we conclude the mandible by talking about its movements and the muscle forces involved, considering the osteokinematics of the mandible or the observable movements of the bone in space and the arthrokinematics, or the accessory movements, which, for this joint, mainly concern the movements of translation and rotation. We're going to talk about protrusion and retrusion, lateral excursion, depression and elevation. The function of ligaments is to maintain the integrity of the joint. The ligaments are composed of collagenous connective tissue with little elastic capacity, which makes them a passive restraint to limit and circumscribe the movement of the joint. The three functional ligaments that support the TMJ and that we studied in the previous videos are the collateral or discal ligaments, the capsular ligament, the temporomandibular ligament, and the two accessory ligaments, the sphenomandibular ligament and the stylomandibular ligament. The collateral ligaments limit the movement of the disc relative to the condyle. The capsular ligaments act to resist any medial, lateral, and inferior forces that tend to separate the articular surfaces. The lateral portion of the capsular ligament is reinforced by a strong ligament, the temporomandibular ligament, which resists excessive dropping of the condyle, thereby limiting excessive mouth opening. The sphenomandibular ligament does not have a significant effect on mandibular movement, while the stylomandibular ligament limits excessive mandibular protrusion. Protrusion or retrusion refers to relative anterior or posterior translation of the disc and condyle relative to the mandibular fossa respectively. Protrusion occurs when the condyle and disc translate anteriorly relative to the fossa and follow the inclination of the joint eminence during movement. It consists of an anterior translation in the absence of relevant rotation. Actually, the movement is not pure translation, but is accompanied by postero-anterior and top-to-bottom movement. Maximum condylar translation is considered to be 1.25 centimeters amplitude in an adult. During retrusion, the mandible slides posteriorly and slightly upward in the reverse direction. The translatory component is limited. Lateral excursion refers to the lateral translation of the disc and condyle over the mandibular fossa. The ipsilateral condyle has minimal movement, while the contralateral condyle moves anteriorly and medially. This movement is usually associated with slight rotation. The condyle on the side of lateral excursion acts as a fixed pivot that allows rotational movement of the contralateral condyle, generating a mean lateral displacement of the mandible of about 11 millimeters. Depression causes the mouth to open. The average opening is about 50 millimeters and corresponds to the insertion of 3 knuckles inside the mouth. It consists of 2 phases. The initial phase, constituting the first 35 to 50% of the range of motion, mainly involves rotation of the mandible. The condyle rolls posteriorly, rotates clockwise, on the lower surface of the disc with a slight interior translation. During the final phase, in the last 50 to 65% of total range of motion, there is translation of the condyle and disc anteriorly over the mandibular fossa and the joint eminence, like protrusion. During translation, the condyle and disc slide together anteriorly and inferiorly against the slope of the articular eminence. Protrusion and depression are limited by the superior retrodiscal lamina, which is stretched, so that the disc always remains interposed between the temporal bone and the mandible. Closure occurs in reverse order. It is called elevation and has an arthrokinematic dynamic opposite to that of depression. When the mouth is fully open and prepared to close, tension in the superior retrodiscal lamina begins to retract the disc, facilitating the first phase of closure. The next phase is characterized by rotation of the condyle within the concavity of the disc, which ends when contact between the upper and lower dental arch occurs. The muscles that play a role in TMJ movement are divided into 2 categories. The primary muscles of mastication. The best-known group consists of 4 muscles that work in pairs and are primarily responsible for TMJ function and mandibular movement. They include the masseter and temporalis muscles, which are responsible for mandible closure. The medial pterygoid muscle, which is responsible for the closure and lateral movements of the mandible. A unilateral contraction of this muscle produces a contralateral excursion of the mandible. And the lateral pterygoid muscle, responsible for opening, lateral deviation, and anterior movement of the mandible. Unilateral contraction of both heads produces contralateral excursion of the mandible and rotates the ipsilateral condyle anteriorly and medially within the horizontal plane. Bilateral contraction of both heads produces protrusion of the mandible. The accessory muscles can be divided into muscles directly associated with mandibular function. The opening of the mandible is assisted by a series of paired muscles that coordinate the complete integration of mandibular movement during opening and closing through their insertion to the hyoid bone, mandible, and other bones that we will review in the videos on swallowing, and in accessory muscles indirectly associated with mandibular function. These muscles are located in the cervical area, including the sternocleidomastoid and the anterior, middle, and posterior scalene muscles, and attached to the sternum, temporal bone, clavicle, cervical vertebra, and the first pair of ribs. These muscles stabilize the skull and neck and allow the mandible to move relative to the skull. The buccinator muscle is sometimes called the accessory muscle of mastication because it coordinates with the orbicularis and superior constrictor muscle during swallowing, mastication, and phonation. The buccinator, the main cheek muscle, originates from the mandible, the alveolar process of the maxilla, the alveolar part of the mandible, and the pterygomandibular raphe. The muscle, then, inserts on the angle of the mouth and the orbicularis. The buccinator lies deeper than the facial skin, the anterior border of the masseter, and the more superficial muscles. Extrinsic tongue muscles have the function of raising, depressing, retracting, or protruding the tongue. Intrinsic tongue muscles have their origin and insertion within the tongue and are involved primarily in changing the shape of the tongue. Although gravity helps open the mouth, significant muscle activation is required to open it fully. Opening is accomplished through contraction of the inferior head of the lateral pterygoid and the suprahyoid muscle group. The inferior head of the lateral pterygoid is responsible for protrusion of the mandibular condyle. The disc is pulled anteriorly by the condyle in translation and by the activation of the inferior head of the lateral pterygoid. The bundle of the lateral pterygoid that attaches directly to the disc is relatively inactive during mouth opening and closing. The infrahyoid muscles stabilize the hyoid bone so that the suprahyoid muscles have a firm base to help with mandible depression. Closure against resistance is performed by contraction of the masseter, medial pterygoid, and temporalis muscles. The posterior fibers of the temporalis muscle also retract the mandible, helping to rearrange the condyle within the mandibular fossa. The superior head of the lateral pterygoid is eccentrically active by balancing the retrusion forces. The primary muscles of mastication are innervated by the mandibular nerve, a division of the trigeminal nerve. The central part of the disc lacks sensory innervation, while the peripheral parts of the disc and the retrodiscal and capsular tissues possess pain fibers and mechanoreceptors. Sensory innervation of the temporomandibular joint occurs through two branches of the mandibular nerve, auricolotemporal and masseteric nerve. Secondary muscles. The anterior belly of digastric and mylohyoid from the inferior alveolar nerve, branch of 5-3. The posterior belly of digastric and stylohyoid from the seventh pair of cranial nerves, facial nerve. The geniohyoid from the hypoglossus, 12th pair of cranial nerves. Mastication is a complex physiological function given by the sum of all the movements seen above. The act of mastication generally occurs on one side of the mouth at a time, called the working side, while the opposite side is known as the non-working side. The working side coincides with the side toward which the mandible moves, while the non-working side is the side from which the mandible has moved away. The condyle of the working side rotates about the vertical axis during lateral excursion of the mandible due to contraction of the temporalis muscle, medial pterygoid, and masseter muscles. In this side, there is an opening of the mouth, with therefore no tooth contact. The non-working condyle moves medially before forward motion, occurs due to contraction of the lateral pterygoid, resulting in dental occlusion, which allows mastication. With this, we have concluded the chapter of the mandible. I recommend these videos related to the topics we covered today. See you next time.